Okay, so hi everybody. If you've been with us over the last few days, you already know me, but my name is Alissa Terry. I'm a genetic counselor and the project manager for NIMAC. We have a really great panel of people to talk with us today about lessons in telegenetics. We do not have any relevant financial disclosures. So I mentioned on the first day that telegenetics is one of the key areas that NIMAC focuses on to improve access to genetic services. The challenges that many families face in our region, getting to a genetics clinic was a big motivation for us to start exploring and supporting telegenetics about 5 years ago. The visuals that you see here were developed by families in our region to explain telegenetics to other families. When I'm talking about telegenetics, most people think about live video meetings like this one, and that often happens, but sometimes telegenetics happens over the phone. Sometimes records and documents are sent to a provider without a live meeting. We call that store and forward. Sometimes a doctor keeps track of a person's signs and symptoms and sends that information electronically for evaluation. That's called remote patient monitoring. And then finally, when communication happens on mobile devices by texting or apps or video messages, that's called mobile health. With our overall goal being to expand access, we see from studies that telegenetics really can improve access and reduce cost, wait time, and travel for patients. And even before COVID, we were able to see that there were telegenetics programs in the NIMAC region and a lot of interest at that time. We all know that telegenetics and telehealth were really important during COVID. And we're going to share the link to this infographic that you're seeing on the screen in the chat, so you can check that out. So in the summer of 2020, we explored patterns of telegenetics use across the region, and we'd love to see how your experiences compare to that. So if you're a provider, we're going to put a quick poll up and just ask how you were doing with telehealth before COVID, how you used it during, and what your thoughts are for afterward. So I'll give that just a minute, and we'll take a look at how the experiences of the people in this room compare to the people that answered our survey a year and a half ago when things were just getting started. And this is certainly an ongoing area of question for NIMAC as we try to figure out how to continue to support people that want to do telegenetics. Their needs are different now than they were 5 years ago. So we're still learning from people what's happening and how they're adapting things and doing new things. So Fred, whenever you think that that is looking.
We've got some responses still coming in.
Okay.
It looks like, no, maybe we're stabilizing. So I'm going to close the poll in 5, 4, 3, 2, 1. And there are the results.
Great. Okay, so about almost 70% of people were doing mostly in-person visits and only about a quarter live video, about half phone before COVID. And then you obviously see this pretty significant shift to almost everybody having experience with live video and phone consultations post-COVID, not so much with store and forward or the other forms. And everybody either definitely planning to keep going or in the maybe camp. So I understand that sometimes we don't even have control over whether we're going to keep doing telehealth or not. That makes sense. So what we observed when we asked those questions is pretty similar to what you guys just shared. Again, we were asking this in the summer of 2020, which is still relatively in the beginning of the pandemic, actually. So we weren't quite seeing those numbers we just saw of basically almost everyone doing telehealth, but certainly a really big shift, which really everybody knows. And as you guys just expressed, almost everybody at that time also was hoping to continue. You know, maybe they were saying maybe sometimes, but very few people actually planned to discontinue telehealth. So overall, I think that most of us feel like it's here to stay in some way, shape, or form, but we'll have to sort of stay tuned on how that gets adapted. So what I want to ask you now is what you think is the biggest barrier to the use of telehealth. So this one is for everybody, families, advocates, providers. We're going to put a poll up with some choices, and you tell us what you think is the biggest thing that gets in the way when people want to use telehealth and telegenetics.
Hey, Alyssa.
Yep.
What's missing on here is lack of Wi-Fi / equipment, or is that the appropriate technology?
Yeah, we definitely had to, you can only put 10 options. So that's how we ended up with general categories like that. But for sure, we're going to talk about issues with broadband, Wi-Fi, and cell coverage for sure.
Thank you.
Yep.
So I see these responses are starting to stabilize. So I am going to go ahead and close that poll in 5, 4, 3, 2, 1. And there are the results.
Perfect. Okay. So technology seems to be a pretty significant issue. And as TC just said, that may have to do with both computers, phones, iPads, things like that, as well as access to internet, broadband, cell phone coverage, all those things. And we certainly see licensure and legal and funding. Making some notes so that when we get to pick the brains of our panelists, we can ask some of these questions. So I appreciate your input there. That's very helpful. So there always are going to be barriers to new models of care. It's interesting to look at what we got from the providers in our survey in terms of what got in the way before COVID versus after. So in particular, we saw this big shift in these categories of pre-COVID. People were citing a lack of patient interest, a lack of provider interest, and a lack of institutional support being pretty big problems in their desire to implement telehealth when they wanted to. And those things pretty much went away post pandemic. So now providers are interested, patients are interested, institutions are supportive, and now we're seeing these new problems emerge. So as I described, NIMAC is one institution, but other organizations are also making this shift in the supports that we provide to people because the problems are evolving as the practice of telehealth gets so much more ubiquitous. So we're also very aware and hear from communities there are unique barriers to telehealth in underserved communities. Some of these involve the lack of equipment like smartphones and computers, lack of technology skills and digital literacy, or as we were just talking about, lack of internet and cell phone coverage. So we definitely recognize that underserved communities have different access to telehealth than other communities do. And there is a lot of work and a lot of funding going into exploring and addressing these types of disparities. We'll share this link, but it's a huge area of conversation. And the ability to use a simple phone call to provide care changed a lot during the pandemic and was really important to the continuation of care for families that couldn't access video visits. Audio-only visits didn't used to be covered by most insurances as telehealth, and the coverage post-pandemic remains a little unclear. But CMS did say that state Medicaid programs may choose to continue to reimburse for audio-only services as a permanent policy. So we're going to have to kind of stay tuned to see how that remains or does not stay in place as part of the telehealth services that providers are able to offer. Another great solution to those types of barriers to telehealth is to set up telehealth locations within the community for families that can't access services from home. This is just one example of the Delaware libraries providing space for telehealth appointments and or loaning out devices. But I've seen this across many states. I know Hawaii is doing a great job with this, and there's many other states that are setting up these sites to give this to families that want to do telehealth but can't do it right from their home. Another really interesting thing that one of our panelists shared with me is that we're seeing a role for companies like Lyft, Uber, and ride sharing to allow patients either to get to clinical appointments, get to telehealth sites, or it can sometimes even deliver the technology they need right to their homes. We've also seen some futuristic ideas about cars or vans that can drive around neighborhoods, and the car itself is all equipped with telehealth equipment, so it can come park in front of the house. Family comes out, sits in the car, does their appointment, car drives away. So I think that's a little bit further off, but it's something that we've actually seen modeled, which is incredibly cool. So lots of creative solutions to some of these issues. A lot of them need to be studied and figured out more, but people are definitely thinking about it. So NIMAC is aimed to support providers that wish to use telegenetics in a number of ways. We do offer technical assistance, education and training, and collaborative funding. On the whole, we've seen big successes. We've been able to impact lots of providers with a total of about 20,000 patients having been seen by telegenetics in NIMAC supported clinics in the last 4 years. Here's just a quick flyer about a training that we're offering. So this is going to take place April 21st or May 11th. So this is available to genetics providers if anyone is interested in kind of learning more about how to perform telegenetics. My email is in the chat. You can email me directly. And these are just a few examples of some of the telegenetics education events we've done in the past. These are all recorded and available, and we certainly always touch on telegenetics at our annual meeting, just like we're doing right now, and we did last year, and that's recorded and available too. We do have an online toolkit in partnership with the Mid-Atlantic Telehealth Resource Center, and we'll drop the link to the chat in the chat for that toolkit. And lastly, we're happy to be able to provide funding to some of our groups for telegenetics. We've funded 11 groups now that have really made huge strides in the reach that they're making with patients by telehealth. So we look forward to continuing those funding projects. As I stated, the other regional networks also do great work in telehealth. They have work groups, videos, infographics. We're going to drop some resources in the chat here. I encourage you to check those out, because we are certainly not the only ones that are working on telegenetics. Just a quick mention, some genetics clinics are using other types of cool technology, things like chatbots to answer questions, online family history collection tools, databases, risk calculators, even artificial intelligence to look at facial recognition to make a diagnosis. So there's a lot of other neat things on the horizon that may be part of telehealth or may just be another way to use technology. Telehealth resource centers are also federally funded organizations. They provide assistance, education, and information to organizations interested in providing health at a distance. We have 3 people from the telehealth resource centers here today. They will be introducing themselves to you in just a moment. But if you're not familiar with the telehealth resource centers and which one covers your state or district, I encourage you to check those out. So I'm not going to go into a lot of detail right now, but some of the policies about what you can and can't do with telemedicine include licensure, credentialing, Medicare, state Medicaid, state telemedicine laws, private payer policy, rules about telemedicine and prescribing, consent, privacy, and fraud. So there are a lot of things to pay attention to for anyone that's setting up a telehealth structure, a new program. And a good way to keep your eye on that is through the Center for Connected Health Policy. So I'm curious if you can quickly share with us what policy changes you have questions about. Again, this will help us shape some questions for our panelists. So if you can take a quick look at the poll there and let us know what you're curious about.
And those responses are coming in.
Great.
As people read and consider. I did set it that it's a single answer, so people had to choose.
Okay.
We have a slight front runner, or no, actually a pretty even split between 2.
2 is doable.
Yep. So I'm going to go ahead and end this poll in 5, 4, 3, 2, 1. Yeah, Megan says I would select so many of those.
Yeah.
But here's what people selected when forced to choose one.
Okay. So state policy and licensure and credentialing. Yep, those are big ones. Okay, so I will make sure we touch on those. They're all important. I agree with you. And we'll get to all of them if we can, but just wanted to hear from you guys where the biggest questions we're feeling. And again, I encourage you guys to check out the Center for Connected Health Policy that covers a lot of those types of policy and can help keep us all up to date, because lately keeping up to date on telehealth policy is basically a full-time job because everything keeps changing. So one of our panelists was kind enough to share a few slides about some legislation to keep an eye on, such as allowing patients to receive telehealth at home, allowing patients in any geographic area to receive telehealth, allowing federally qualified health centers or rural health centers to serve as telehealth providers for telehealth services to patients, and consideration of extending some of the telehealth expansions we saw during the pandemic for some set period of time that's not directly related to the public health emergency. So keep those in mind. For people that are really familiar with Medicare and how doctors get paid, we just want to quickly mention that Medicare has extended some of the new coverage that it allowed during COVID. What they classify as Category 3 services will be covered until the end of 2023. But for anything that was just temporarily available, those will end when the public health emergency ends. Although we do see some of these telehealth services in the Category 3 group, none have been added to the permanent or temporary categories yet. So we're all thinking about, you know, when the public health emergency is officially over, what's going to change. So this helps us keep an eye on what Medicare is telling us is going to change. There are a couple other circumstances where the rules for telehealth don't apply to some models of care. Some things that are done by phone or video that don't have a similar face-to-face service are considered communication technology-based services. These are not considered telehealth. So this might include things like a virtual check-in, remote patient monitoring, principal care management, and chronic care management. So with this in mind, we just see these possible opportunities for certain technology-based services that don't have those face-to-face equivalents to be covered more broadly. It's important to note too that the Medicare Advantage plans have different telehealth rules and have the ability to cover things that fee-for-service Medicare does not, such as visits to home and coverage to non-rural areas. This is also true for managed Medicaid plans. So again, this is an opportunity to start building a case for managed Medicaid providers around the value of these telehealth services. So basically different plans have different policies, as we all know. Okay, so with that, I really want to welcome our panel today. I mentioned the telehealth resource centers a few minutes ago, and across our 10 NIMEC jurisdictions, there are 3 telehealth resource centers that we work with. Dr. Kathy Wibberly from the Mid-Atlantic Telehealth Resource Center covers part of New Jersey, as well as Virginia, West Virginia, Pennsylvania, Delaware, DC, and Maryland. Lloyd Sermons from the Southeast Telehealth Resource Center covers Puerto Rico and the Virgin Islands. And Danielle Lauder from the Northeast Telehealth Resource Center covers New York and part of New Jersey. We also have with us genetic counselor Eleanor Schwind from Mount Sinai Cystic Fibrosis Center. And we are so lucky to have 2 parents with us who are willing to share their telegenetics experiences with us. Deanna Brand and Miranda Miller are both parents who have received telegenetic services. So welcome to all of our panelists and thank you for being here.
Thank you.
I'm going to stop sharing so you can focus on them. And what I wanted to start with you guys, I'm going to ask you to just introduce yourself and tell us what do you think in your own experience is the biggest advantage of telehealth? So what is telehealth giving us that is so useful? So I'm going to start with Miranda.
Hi, thank you again for having me. I think one of the obvious advantages, maybe not so obvious, but for us was accessibility, especially during pandemic. Also remote, we're further away from our provider, so it made scheduling much easier I'm a patient myself, and I also I'm the parent of a pediatric patient. So coordinating care, making it more accessible as far as busy schedules. We are further out from our provider, and we are also higher risk. So during the pandemic, it made it possible for us to proceed in care and proceed to find answers for some issues we both were having alongside our other providers. So it helped keep the delay minimal and our other care was impacted because of that in a positive way. And it helped us be comfortable and get services when otherwise we'd be delayed 2 years or so.
Yeah,
so
that's great. Miranda, had you ever done any telehealth before COVID happened, or was that the first time?
I may have 1 or 2 appointments, and if we're including a call, perhaps, but no, not that I can remember distinctly. No.
Yeah. Yeah. No, that's
And I
pretty
have
normal.
many specialists, probably like a lot of your patients, between myself and the patient I advocate for, my child. We have a lot of doctors, so I've had a lot of experience now at this point with telemedicine, thankfully.
Yeah.
But genetics was a vital component because it helped answer a lot of questions those specialists had. So it helped us in our journey.
Perfect. Thank you so much. And Deanna, how about you? What do you think is the biggest advantage? And please introduce yourself.
My name is Deanna Brand, and I have a 5-year-old that needs telehealth because, well, for one, our immune system isn't that great. So going into a hospital is really a big no-no for us. He was getting sicker taking him into the hospitals versus the telehealth visit. So it really helped out with that. Even before COVID, I think telehealth would have been a good thing for my son, just to keep him healthy, basically.
Mm-hmm. Absolutely. And Eleanor, how about you from sort of the clinician's perspective, and introduce yourself?
Hello, I'm so happy to be here. I'm Eleanor Langfelder-Schwind. I'm a genetic counselor specializing in cystic fibrosis at Mount Sinai Beth Israel in New York City. So I really appreciate the patient perspectives on how beneficial telehealth has been. I think, like Deanna, my patients also have issues with infection control and being in a place where they could potentially have exposure to bacteria, or in this case, or in the world we live in COVID. Telehealth has been really a saving grace for them. Our patients did really, really well in COVID, partly I think because they were able to be tucked away and also have access to their care teams in a way they didn't have before. So I think that's been the main benefit lately. And then of course it's given us a new way of thinking about delivery of care. In my own position as a genetic counselor, because I don't actually lay hands on the patients, I was able to provide care from my own home with the patients who needed to have hands-on at the originating site in the clinic, or sometimes home to home.
Yeah.
Can't wait to learn more. And Alissa, I think you did a great job of outlining so many benefits of telehealth, so I don't want to repeat you.
Perfect. Thank you. Danielle, how about you? What are you seeing in sort of the New England region that's going well with telehealth?
Sure. So as Alissa mentioned, I serve as the director of the Northeast Telehealth Resource Center, and we actually serve all 6 New England states and New York. And now Kathy has all of New Jersey.
Oh,
but Jersey, yes, HRSA changed us over last funding period. However, Jersey, if you call us, we are going to be there for you. And we'll work it out with Kathy because we're it's like that. So I think I am super excited to hear, from the patient and family perspective and provider perspective, all the things that we would expect and that we've known about benefits of telehealth over the years. I think, just not to duplicate that, but the snowball effect that's created with positive impact, the access, parents being able to participate in multidisciplinary visits with different providers, but they might not ever be able to do that. So I think that's maybe a new one that we haven't necessarily mentioned, but we've seen a whole lot of it, particularly during COVID, with people being a lot more willing to try telehealth, or they had to try telehealth, that they got really creative and innovative, and they're bringing together a lot of different types of providers in that integrated care model that might not necessarily be possible before. So
yeah, that's a great one. Thank you. Kathy, how about you?
All right, I'm Kathy Wibberley, and as mentioned, I'm director of the Mid-Atlantic Telehealth Resource Center. Since I work mostly with providers, these are the things that I've been hearing a lot. One is a decrease in no-shows, and I think for all the obvious reasons. Patients don't have all those barriers to, childcare, taking off from work, getting transportation, paying for gas. I mean, all of those things play into that. But I think another thing that I've heard, and that probably shouldn't be a surprise to me, but I think the providers are saying, we get to actually know what's going on in that home. And so we talk so much about social determinants of health. And, when a patient comes into the office, like none of that is obvious. And when you are at home in video, you can actually look and see like there's no food in the kitchen. There's nothing in the refrigerator. There are medication bottles that are unopened sitting on the counter. I mean, things like that you really don't get a good sense of when you are like seeing a patient physically in the office.
Yep. That's a perfect point. I love that point. We hear that a lot. That was one of the things that I had never thought of either. And we've heard that from so many of our providers and families, that the kids are more comfortable when they're not in a weird environment they've never been in, and they kind of maybe show their skills a little bit better if the providers are really trying to get a clear sense of what the kids are capable of. And we get to meet their pets, says Eleanor. Definitely. And you get to see, sometimes you get to see other family members that wouldn't have come to an in-person appointment. And in genetics, sometimes that can be super relevant if grandma happens to be there and she has some role to play in this. So that can happen too. Okay, Lloyd, please introduce yourself and you share with us.
Yeah, so I'm Lloyd Sermons. I serve as the director of the Southeastern Telehealth Resource Center, and I'm based actually in South Georgia. And I was just going to say, one of the big things is the pets that get to be involved in the telemedicine consults now. But no, it is kind of funny that has kind of become somewhat of a norm. But I think one of the things we see, and I live in kind of a very rural area. So when we go to the physician, especially from a specialty care standpoint, a lot of the times we're driving at least an hour, for those appointments. And so I know, kind of personally for us, being able to bring the physician to the patient, I think is tremendous. As Miranda and Deanna kind of talked about that access, creating a kind of a, I hate to use the term convenience, but I mean, really to some degree it is. I have children, and having a young daughter, we participate in the school-based telemedicine program, which is awesome, but yeah. I think one of the things too, we often try to, we attribute this to rural healthcare, but if you've ever had to try to navigate somewhere like Atlanta, Georgia, or Miami, Florida, or Jacksonville, Florida, it's very tough for patients to travel to meet appointments in those facilities. And when you start dealing with patients that are in, skilled nursing facilities and long-term care homes and things of that nature, it's not just about rural anymore. It's just access, period. And yeah. So I think for us, with the area, the region that I particularly cover, I mean, that's by far one of our bigger points there. So.
Absolutely. Thank you. So one of the things that always comes up and was talked about as I was going through is that the same program of telehealth doesn't work for everybody, because there's some communities that don't have some piece of the puzzle that they need to make telehealth work, whether it's the equipment or the broadband or something like that. So we saw some examples of creative solutions to that problem. I'm just wondering if anyone has had experiences that they can share of ways that actually worked to overcome barriers for underserved populations.
Alissa, I can hop on and just share some of the federally qualified health centers that we've worked with within our region. And this could really be applied anywhere. It doesn't matter the specific type of environment. There are several programs that assist with subsidies for whether it's devices that weren't necessarily available for folks beforehand, or the monthly fees that are associated. We know there's connectivity in some places, but it's not affordable. So we can almost say it might as well not even be there, right? So if it's not affordable, they don't have so there are programs that would assist folks with devices and or subsidies for their monthly fees associated with data packages, et cetera, through the Federal Communications Commission, for example. The Lifeline program has been around for many years, but there has been some pretty strong feedback that the process of applying for it can be a little intimidating and quite a bit of work. And so some of the FQHCs in our region they might actually sign them up for programs like the Lifeline through telehealth, even using they might come in on site and they would get them signed up during that period of time, or they would work with them to sign up for the Lifeline program during a telehealth visit. So that's been a really great success story in our region.
Yeah.
I'll put that in the chat too, the different resources to.
Yeah, that would be great. Thank you.
Yeah, and Lynn put the thing about borrowing hotspots from libraries, and we're seeing that happening in many, many library systems, being able to borrow those. So that's a big one. This is not the optimal, but we have definitely seen people making available Wi-Fi to like in parking lots and in storefronts and things like that, where people can drive their car, park in front, and actually do that. Again, it's not the optimal, but it is one way to access Wi-Fi, whether it's a school parking lot or just a downtown mall parking lot type thing.
Yep. Deanna or Miranda, do you have any input on, if you met another family that was struggling to do what they needed to do to get onto a telehealth appointment? What do you think would make life easier for families?
Okay, one issue I've ran into, it was not the devices itself, it was getting access to the doctor. A lot of the doctors aren't licensed in all of the states. So it makes it to where you either have to go with your computer into the state that they're licensed in, or go to the hospital, or you end up paying for it if you do this telehealth outside of the state that your doctor is licensed in. So one issue that I've run into, and I don't want to change doctors. That's the other thing. You don't want to lose your doctor because
because she's the best.
Exactly. I'm like, then I gotta move.
Yeah.
What was your question specifically for again?
I'm just for families that would have a hard time getting a telehealth appointment at home. I'm just curious if you have thoughts on what should be done. How can telehealth programs be built so that they're as easy as possible for families to be able to use?
I have feedback as far as the model. Accessibility, I know obviously you guys address a lot of it with Wi-Fi technology. I like the telephone component if you don't have a great stable internet connection, especially rural families. A lot of issues we came in even with technology was having something sufficient enough to get the data that the provider needed at the time of the appointment, like especially in genetics, to see certain lesions on your skin or features of your pharynx, like looking in your throat, or like it's harder for those data points. So I don't know if that comes in the sorts of tools. I would love to see some growth and preparation as far as preparing the patient on what to expect, like how to dress, like be prepared to be able to show your back. Because if your kid's wearing something strappy or crazy, or make sure you're in a well-lit situation, have a flashlight available, certain basic components that can make it easier for us as parents. And I myself also am a patient, but so we're not wasting anyone's time during the appointment running to go grab a flashlight or helping somebody untie 3 ties on the back of their fancy shirt because you don't think about these things. It's the opposite side of the convenience, right? You're just at home, so you're like, oh, I need to get in so if they could send something ahead of time to make it easier and access in that way to know, think for something comfortable, wear gym shorts and a loose t-shirt, have a flashlight available, have a camera available. So if we can't see now, you can take a picture and send it to this after, which we worked our way through. We kind of fumbled our way during the program, but as far as efficiency goes and of the appointment, and with children, one of the other sides of the coin, not negative, but you're in their home and they're more comfortable, but they're also more distractible. So keeping certain ages being like, no, don't go turn the TV on. Don't go to your switch, leave the dog alone. Like you need to sit right here. They're like, why would I sit right here when I can go right outside? And you're just like trying to wrestle them. So those are the other, I don't know if that's accessibility. I know it's functionality of the program and using the most of your time for the provider and the patient. Stable internet is wonderful, or having those workarounds with telephone, and then being prepared to take photographs and send them later when you can get a Wi-Fi signal. So if you are going to a location that's remote, where you're going to Starbucks or the library, I need a list of these photographs. Give me a photograph of the abdomen, of this, that, and that, and then having a HIPAA compliant way to send those over, or however you're comfortable. But just, yeah, having all that and then preparing beforehand for the appointment so that you have everything you need. So again, it goes smoothly.
Yeah. Yeah. No, I think clear communication with the family before the appointment, you know, between the time the appointment is scheduled and when it's actually going to happen, so that they understand exactly what they're going to need. And like you said, sometimes we need these funny tools that would have never occurred to you that you might need. And I think Miranda brings up
some families might not have a flashlight. So
of course
get into that as well when there's disparities.
Or you do, but you can't find it that day, which is usually what happens.
Yeah. Using the phone and stuff. So I've seen a lot, but no,
I think that's very true. That
Dr. Sure has been exceptional in that regard. And like, but I'm sure as providers, you can say when you go into these appointments, you don't always know what's going to lead you to want to see something else. So we've been in a situation where I mentioned something offhand and she was like, oh, I need to see that. And we didn't know that going into the appointment until we went through a list of things. And she was like, oh, I need to see a picture of that. And you're like, oh,
yeah.
So she wouldn't have known that going in either. So it does need to be adaptable somewhat, but.
Yeah. Helps when everybody has a little bit of flexibility in the moment. Cause as you said, with genetics, sometimes those clues, we don't even know what clues we're going to get in real time. So to be there, but I think the fundamental point of really clear communication about what is needed to have that appointment at home, and whether that includes the technology, the broadband, the little tools that you might need privacy if we're going to ask you to show parts of your body that you normally wouldn't be showing on camera. Which happens. And if you're not comfortable doing that, then that may be a consideration that it's not a great time for a telehealth appointment, and that's fine. You know, some families may not feel comfortable doing that. And I think that is one really important thing to communicate ahead of time. Deanna mentioned just a moment ago the issue with providers and state licensure. So I'm wondering if one of our telehealth resource center people can give us a high level summary on how it works, how it's temporarily working differently, and where you think we're going.
I mean, I'll kind of go take a stab at it first, and then I'll let Danielle and Kathy kind of jump in. But you know, we have 2 states in my territory who have created like a virtual license, which has been fabulous. You know, Florida, you know, they have a telemedicine license. Georgia has a virtual license as well. And so basically what that does, because licensure follows the patient, right, at the time of service. So, you know, if you're in Georgia, then your provider has to be licensed in the state of Georgia, unless there's some special circumstances that are made through the licensure body. So what, you know, what we have seen here with Florida and with Georgia, you know, that license it's a full license to practice in the state. You can't practice physically in the state, but you can practice virtually. And so, you know, that has kind of opened some doors for telemedicine, because of course, you know, the one thing that that the virtual care has kind of created is that ability for, you know, providers to be kind of anywhere, and then but be able to practice across those state lines. And it's very cumbersome. Some states are, you know, from a licensure standpoint, it's you know, it's different in every state. Every state licensing board, you know, has their own fees. It costs different. There's different processes by which you apply. Some, from what I hear, are more difficult than others. So if you're a physician and you're carrying multiple, you know, state licenses, then, I mean, just imagine the cost, trying to keep up with the license when they're expired, when they need to renew, you know, all these things that come with that. So, you know, I mean, I think we could potentially see, I mean, of course, there was you know, a time where they were trying to push for, you know, kind of like what the VA does with reciprocity. And that kind of got, you know, kind of shot down. And so now we're seeing these compacts and, you know, all these things that are happening to try to alleviate some of that burden. But I really like what Florida and Georgia kind of have done in the fact that they've created that virtual license. And so now you can get that virtual license. You're not allowed to practice physically in the state. That license doesn't allow you to do that. But, you know, in most instances, when you're a physician in, you know, as we've gotten calls from, you know, people from like New York, New Jersey, and they're just wanting to see patients who are traveling down to these states, you know, snowbirds, kind of those ideas.
Yep.
And so it really kind of helps out a lot. So.
Yep.
Yeah, I would add to what Lloyd said. You know, what we're seeing is a trend definitely toward the licensure compacts and more states joining them and more professions creating them. We're seeing in my region a lot of legislation being proposed about bordering states. So if you are, you know, if you are a practice and you border around, on another state, that they kind of have reciprocity for those bordering areas. And some of them have kind of restrictions, like your practice needs to have a site or a location like physically near, you know, the border of a state, and then, you know, that state would accept your license for reciprocity. We're also seeing a little bit of a trend toward, like, if you have an established patient, like you've seen this patient face to face, like physically in person, and now this is an established patient, and therefore will allow some flexibilities for telehealth in those situations. So I think, you know, we're definitely going to see more and more of this as people push on this, and this is, you know, particularly relevant for specialty care because there just aren't specialists everywhere, and so, you know, you really just can't have that. You know, you have to be in the state where the patient is physically located and licensed in every one of those states. So I think it'll be interesting, but we're definitely seeing movement toward greater flexibility with the licensure piece.
Yeah.
Yeah, I would add that there are, TC had asked about different types of compacts, and that the medical compact, licensure compact has been helpful for him. Especially the burden of the paperwork was really the benefit of that, right? And the goal of that. I think there's only one medical compact that I'm aware of for physicians, but there are a lot of them. The nursing compact's been around for years, well before the medical, and then the psychology, there's a compact for that. And we're seeing a lot more being introduced because of COVID, and because of some of these, you know, sort of opportunities and challenges that we've seen arise during COVID.
Yeah. Jessica had a question about states covering genetic counseling. Jessica, one of the things that complicates this issue for genetic counselors is that not all states have licensure for genetic counselors. So you're sort of dealing with, you know, with physicians, at least it's uniform that every state has some sort of licensure, and then they can start to make agreements about when they'll make exceptions. But when there's this weird patchwork of whether or not there's even licensure, sometimes it gets a little more complicated. But in states where there doesn't happen to be genetic counseling licensure, then you have a little more flexibility there for patients that live there because there is not licensure. So that's why it's not quite as straightforward for genetic counselors as it is for some of our other providers. Lynn was sharing an experience that her child, in order to maintain continuity of care, was told that he could only be in New York State because that's where, you know, the provider only had that one license. And I think that your experience is accurate, Lynn, if that's the only license that the provider has and doesn't have plans or intentions to get one somewhere else, that is, you know, a problem that we're all describing. Is if you're desiring that continuity of care, that will be a boundary, you know, kind of almost a physical boundary.
Yeah, that's the case. The provider is a snowbird, and he provides telehealth services even before COVID. He was doing telehealth, and now with Aiden graduating from high school and continuing on to college, we were looking at college options, and was told that he would have to remain in New York in order to get the continuation of care. But it just doesn't seem fair, you know. Aiden is very limited, and, you know, thankfully New York's got great colleges, it's a big state, but the provider's allowed to be out of town, but Aiden is not allowed to be out of state.
Right.
We have been advising like patients who have these complicated situations like this to go ahead and just contact their state licensing board, because many licensing boards will basically say that they'll be lenient if it's an established relationship, if the person is just temporarily out of state, or, you know, a college student or whatever. They will generally, you know, say, yeah, it's fine with us. So just, you know, don't be afraid to contact them and just explain your situation.
All right, thank you, Kathy. That was never told to us. He's actually a senior now. He's deciding between two colleges or both in New York, so we won't have this problem, but that would have been a good information to have. Thankfully, he has some great choices here, though.
Yeah,
Yeah,
that's a
and
good
I
tip
think-
for everybody.
Yeah, and Kathy makes a good point. You know, I've heard from people on licensing boards, you know, they're not going after, you know, people who are seeing, you know, established patients who are just happen to be out of state, whether you're college, vacation, or you're just traveling down for a few months. I mean, you know, what they're really trying to eliminate is, you know, people who are practicing unlicensed or who have, you know, marks against their license who shouldn't have a license, you know. I mean, those are the type of people that that they're trying to really kind of keep from practicing within their state. And
Or
I think it's one of those. Go ahead, Danielle.
Sorry, I was just going to say discontinuity of care, right, too, Lloyd, is another piece that I think they're trying to prevent with this. But in your case, Lynn, it's the exact flip side of that. Like, you want to promote continuity of care when your son went to, you know, if he decided to go to a different state. So.
And we're not giving legal advice by no stretch of the imagination.
Right.
But you know, I mean, this is just what we see kind of on a regular basis. And I just had this conversation with a counselor the other day, saying it was kind of that same, you know, concept. And I think this is where you kind of run into the problem where telemedicine's governed at the state level. You know, really outside of reimbursement from a Medicare CMS standpoint, it's literally, you know, it's governed at the state level. And so what you end up with is, you know, various policies and, you know, reimbursement, and it just really makes for kind of a very difficult, you know, area to navigate, especially when you start talking about providing care. Those of you who do provide direct care to patients, and you're having to try to figure out how to navigate those waters across state lines. That's really one of the big issues that we see. And I'm a huge advocate that I think, you know, I would love to see policies at the federal level that kind of govern telemedicine across the board, across state lines. I think it would make things, you know, so much easier. I just know, just in my region alone, it's all I can do to keep track and keep up with what's happening from state to state. Each one of my states is night and day, and it's very difficult. So I couldn't imagine being a provider trying to provide services virtually and do that across state lines as well. So,
yeah.
I would like to say, as a patient and a patient's parent, that I incurred this a lot. So a lot of, again, because we are higher needs, we have additional specialists. Most of my specialists are in metropolitan areas, out of state, close to me within an hour or so, but I'm actually technically in another area, another state. So I had to, like, finding providers that were able to provide telehealth in my state while out of where most of the, you know, specialists are in a metropolitan area was a deciding factor for me as a patient and finding care, not just telegenetics, but other specialties. Or not telegenetics, not just genetics, but other specialties. But it was an issue. I even had providers that I had established with that couldn't see me on telehealth because I was not located in their state, even though I was already a patient. Or they would tell me, you have to be in our state during the appointment, which I thought was interesting. So I'm already established with you. Like, how do you know I'm not in my car? I live in a tri-state area. And some of you also, I could literally just drive 15 minutes that way. Like, do I need to go in my car and drive across a border? And then you feel as a patient, like there's a little bit of onus on you ethically. Like, I'm a very ethical person. You're like, okay, do I get a new provider? And again, people with multiple specialty providers, chronic issues, complicated illness, going through diagnostic journeys, it's difficult for them to change providers that way. So, and then after the, you know, if you want to move back to in person, do you keep that same provider after? So the continuity of care again can switch back. So it's very challenging, I think. And Deanna said the same thing. I've all of her issues, she said, I've echoed. Like, we've experienced the same because I'm immune suppressed. My child is immune deficient. So that there are many things you have to consider, but it's challenging. It's an additional challenge for a patient to want to stay with a relationship or create a new relationship with somebody who specializes in their weird or atypical niche, and that you can't see that person because you're not in their state, even though you're 20 minutes away or 45 minutes. So I just,
and it's hard getting a child used to a new provider once they've become accustomed to the provider that we've been working with. So it leaves you at, what do I do?
That trust is that's one good thing about telegenetics. I would say it does enable more trust because you're in the home, the person's comfortable. So it is a better facilitator for trust, I would feel, and we felt that too, because you get to see us in real time and we're not stressed and we can be more vulnerable with you. And the child gets that as well. So the trust is there, and that it is actually, I think, a bridge to trust, unlike being in office, because we can get white coat syndrome and get nervous and all these other things. So, and we don't get to see people without masks in a clinical setting. So seeing each other's faces for children, especially pediatric patients, again, it's a nice facilitator for trust as well.
Yeah, absolutely. It's almost time for us to go back and join the other session, and we're going to hear a little bit about what they talked about over there. But I'm wondering, just Miranda and Deanna, if you want to share with us what you would like to see happening in the world of telehealth 5 years from now. So if we keep doing better and better and better what we're doing, what do you think is the best thing we could be aiming for as a goal to make this as best for families as it can be?
Miranda?
I would love to see integrated tools. So I like the idea of just kind of diving deeper into what has been started, the groundwork that's been laid. So pre-screening, built-in intelligent tools would be amazing. Of course, there's a hierarchy of need as with anything. So make sure you have access, continuity of access or options for those who can't, but then have integrative tools where we can work smarter and more efficiently with our time and the provider's time. So make the appointment go smoothly with preparation, maybe even send a prep kit or have a prep counselor call or a list. So have a better prepared patient, have more intelligent tools available to us that can automate some of the things that can be tedious that we have to repeat every appointment, stuff like that. Tools that work for both us and the provider. So again, like if we forget something, we can go ahead and fill out a form ahead of time or click a couple of questionnaires and it's not tedious. And I would love to have ease of contact, and it would be amazing in 5 years from now if it's just a couple clicks of a button. Scheduling is easier, it's intelligent, and it's just intuitive. The interface is there and the tools have risen to the occasion. So I know that sounds very buzzwordy and generic, but I think you guys have a great start. It's already bridging that gap, forging the relationships, making accessibility more available to people who are rural and immune compromised. And the one other thing you guys touched on, which would be amazing, is if it could integrate better with other specialists, maybe a universal platform or a boilerplate where you can easily send a link, like a Zoom link, and there is policy to support this within other offices out of state and stuff, where you can say, hey, can we make a dual appointment for my geneticist and my pulmonologist and my rheumatologist? And we guys get in a room together, make that easier. So thank you. And perhaps maybe recording so we can review ourselves at our appointment or share the recording with our provider would be awesome.
Love it. Thank you.
Thank you guys for what you're doing. I want to say that. Thank you very much.
Yes, it really helps. It really helps stress-wise because my son is also autistic. So he has a lot of behavior issues, and going into the office, usually the entire office have to be prepared for when we come. So doing telehealth is less stressful because he isn't running around thinking, I'm going to get stuck today. So behavior is on the 100 and, he's just not being still for anyone. So the appointment becomes useless because you can't hear the doctor, and it's more of trying to keep the child calm versus doing the actual appointment. So the telehealth really helps with the stress of being inside of the doctor's office when it comes to my child.
Absolutely. All right. Awesome, guys. So I think Fred is going to direct us of how to join the rest of the group, and we're going to share kind of what we did over here, and they're going to share what they did over there and learn from each other.
And if anyone else on the NIMAC team wants to be the spokesperson for what's happening up here on the screen, I'll bring you up here. And I see some smiles out there. So go ahead and unmute yourself if you're trying to get up here. But we see answers coming in. I'll keep pasting the link in chat.
I heard the my my down the hall mates talk, and again, I think the genetic assistant program here has really helped us enormously, but I was only in that session. And I think that's what people are saying in the Mentimeter here and engagement here.
All right, well, we do have Alissa back here too. Thank you, Julianne. That was a perfect segue. And there's people pouring in from the other session now. So I'm gonna keep putting the link in chat. And Alissa, you ready to take the spotlight here? And yeah, it will unmute yourself.
I am ready. Yep. I was just changing my name.
Oh, you're perfect.
Every time I come back, I have to change my name.
It's true.
All right. So as you guys can see on the screen, we'd really love to share some of the really useful things we got from the session that we attended, so that the people that chose the other session can maybe pull some of those lessons out. So whichever session you went to, share something in this poll that you heard that you think people that attended the other session might benefit from. And this is one of the ones that if you look in the chat, there's a link that you click on that brings you to a website where you answer this question. So I'm seeing from the people that went to the other talk that they learned a lot about genetic assistance as team members and how that really changes the way that clinics flow, and that they can see more families that way, and that they can be an incredible asset to the practice. They also heard over there about virtual assistants and the way that they can similarly impact how many patients can be seen in a genetics clinic, which can be really powerful for everyone, because that is a way to increase access to care when we create situations where clinics can see more people, more families in a day than they used to. Sounds like you discussed in the other room also that generally families are satisfied when they have these encounters with virtual assistants, which is really important to know, because I think for many of us that would be a new idea. So good to know that people are looking at how families feel about that. We certainly had conversations in the telegenetics session about the issues that people are challenged with licensure and telehealth, and how that can sometimes get in the way of maintaining relationships with providers that you've had for a while, if they're not in the state, or if you're not in the state that you need to be. GCAs are pulling their weight and then some. I love that. Adding a lot to the clinic, for sure. All right, guys, thank you for all of that input. So really the goal of this last hour that we had together was to learn from innovative ways to deliver care. In the telegenetics session, we talked about ways that telehealth is making it easier for families and for genetics providers as well, to make sure that families are getting the services they need, as well as talking about the challenges that still remain in using telegenetics. In the novel models of care session, some of our genetics providers talked about how they're doing things in new ways to make more time for more families to be seen during the clinic day, whether that's through the support of emerging technologies like artificial intelligence, or new staff members like genetics assistants. So right now, we're going to give you a little bit of time to share what you learned and what you'll take away from these sessions. As you've experienced over the course of the meeting, in a moment, you're going to see an invitation to join a breakout room. You can choose to accept that invitation and have a really cool small conversation with people about what you learned in your session. As Erica has said, if it's not a good time for you to have that conversation or to be on camera, you don't have to accept that invitation. And if you want to have a conversation in Spanish, there is a special breakout room for our Spanish speakers. So Erica will share with us the directions on how to go have those conversations.
That is exactly right, Alissa. So I've been busy over here making the rooms, and we do have a chat prompt for these cross-pollination discussions. And that is to simply introduce yourself, share which session you attended, and what will you take from these sessions back to your own efforts in genetics to help make genetic clinics more efficient or more effective or more inclusive. So I'm going to put that chat prompt in chat here. So we're moving towards we're in the final hours, the home stretch of the meeting. So really starting to thinking about towards application. How can you take all of this energy, all of these resources, all of these conversations, and how can you bring them into practice? So I will click to open the rooms in just a moment. If you're looking for the Vamos a Charlar en Español room, you'll have to scroll down a bit on the menu because it's a little bit, it's gonna be like a treasure hunt for you to scroll down and find that, because all the rooms are before it. So here you are, there's 7 minutes in the rooms. You'll receive an invitation. As Alissa said, if you're just not a good time, then just decline the invitation and we'll resume back here in 7 minutes.